Hello, dear colleagues. Welcome everybody to this clinical case discussion. My name is Dr. Panagiotis Samaras, and this is my colleague, Dr. Daniel Helbling. We're both from the Onkozentrum in Zürich. We will present a case and we will discuss this interesting case together, and hopefully you will join us in this online discussion. So may I start with the case? It is a 57-year-old female patient. She presented in November of last year due to increasing pain in the perianal region to her general practitioner. She went later on in January 2018 to undergo a colonoscopy, and at this exam a proctitis ulcerosa was suggested, and also a mucosa prolapse syndrome. She underwent a 5-fold elastic ligature at that time, but the symptoms didn't improve the subsequent weeks. She had increasing pain. She was in need of analgesics. And therefore, in March 2018, she was reassessed due to the worsening of the general condition. She underwent again a colonoscopy, and there were skin tag-like lesions at the perianal region observed, and there were biopsies being taken, and the histology showed a well to moderately differentiated adenocarcinoma. Further analysis revealed that the tumor was mismatch repair proficient, and the KRAS mutation in codon 13, exon 2, was found. So later on, there were additional exams being done. She underwent a staging with MRI of the pelvic region and of the abdomen, and also a CT exam. And the further analysis revealed, besides the tumor, also 2 lesions in the liver, suggestive of 2 liver metastases. Small lesions in the segments 4A and segment 8, up to 10 millimeters in size. So this is the case. So we have a patient, a female patient with a deep rectal cancer. It was based on the MRI and endosonography findings at T3N1, and also based on the CT scan and also a PET CT scan, which has also been done, M1 in the liver. So this is the case. Daniel, what is your take on this?
Okay, just to summarize, this was a deep rectal cancer, so very low, far below. How deep? Was it really just in the last 5 centimeters of the rectum? Probably it was really down there.
It was really very deep. It was at the anal region. Okay. So therefore it was misdiagnosed more or less as a mucosa prolapse syndrome, but due to the ulcerations and due to increasing pain and also progressing in size, the reassessment revealed that it was rectal cancer.
And we have metastasis confirmed. There's something also in the groin, the metastasis?
Yes, the PET CT revealed next to the tumor and the 2 liver metastases, 1 positive lymph node in the right groin. That was biopsied, ultrasound guided, and a metastasis there was also confirmed. Okay. So we're having these 3 regions, let's say. We have 1 lymph node in the groin. We have the primary tumor, and we have 2 small liver metastases.
So this lymph node in the groin was externally, it was not a regional lymph node, it was a distant metastasis in that sense. Huh? It was not really close to the primary tumor.
Exactly. So it's not close to the primary tumor, taking into consideration that the tumor is very low down in the anal region. This is a typical way of metastasization. The tumor, but it is not a very close lying lymph node. Yeah.
Okay, fascinating case, Panos, really, and it's a typical case, a complicated case, and it's rectal cancer, and I think what's really the take here is rectal cancer for me with metastasis, there are many strategies to go.
Yes.
And the question is, which strategy do you take, or what is best to take, and what's the rationale to take for which strategy?
Exactly.
So, and I mean, do you think there's a chance for cure, first of all?
Well, I think we can, in this situation, we can fairly say it's an oligometastatic disease. So we have a rectal cancer, a large, locally advanced rectal cancer, but we have 2 hepatic metastases, small in size, both in the right liver lobe, and we have 1 lymph node in the groin. So it is oligometastatic, and I think in this setting, a chance for cure is there.
But
because it's small, it's a small chance, but it is there.
Okay.
I think there are data which showed that even in a small or oligometastatic setting, there is a chance for, let's say, a long-term survival. Let's not talk about cure, but a long-term survival may be possible if you are able to remove everything.
Correct.
So
now the question is to the participants of the tumor, what would they do in such a situation? Which strategy would you take? And we will present our strategy, but really would like to know from you now, how would you approach this patient? Would you first go for the primary? Would you go for the metastasis, systemic chemotherapy? What's your approach? What's your take? How would you approach these patients? We think that this is really there are broad spectrum of opportunities here, of possibilities, and we are really curious to hear your strategy. Thank you.